nodules initially, more so the initial, what happened? The initial evaluation and workup, and then a little bit on like goiters and thyroid cancer as well. I have no disclosures for today's discussion. I'm going to minimize this side here. So objectives, we'll talk a little bit about the epidemiology, some of the etiology of these nodules and risk factors, how to begin a workup and get to a diagnosis. I'll talk a little bit on goiters and thyroid cancer. And in that discussion, a little bit about management and surveillance. So epidemiology, typically clinically apparent, visible to the naked eye, or apparent on physical exam, ranges anywhere from 2% in men to about 5 to 6% in women. 40% of individuals will actually have nodules that are not identified on physical exam and are incidentally found on ultrasound. And through some autopsy surveys and data in the past has demonstrated that anywhere from like 30 to 60% of individuals had thyroid nodules on autopsy surveys. The prevalence of a thyroid nodule or a nodular goiter increases as age increases, starting from like 2 to 3% in the age range of 26 to 30. That increases to 7 to 8% in the mid 30s to 40s, and then up to 12 and 14% in the age of 55. And typically about thyroid cancer only represents 1% of all malignancies and represents about 5% of cases of thyroid nodules are actually malignant nodules. So etiology of thyroid nodules can be broken up into two different categories. We have benign nodules and malignant nodules. The benign nodules comprise of goiters, both multinodular and diffuse. Hashimoto's thyroiditis is a very common cause of diffuse goiters. Thyroid cysts, sometimes they're just cysts alone, and sometimes they're from kind of reabsorbing thyroid nodules that were benign and are now just on their way out. And then, of course, follicular adenomas and other adenomas of other histology. And then our malignant thyroid nodules are your papillary, follicular, medullary, and anaplastic carcinomas, the common bucket of all of your thyroid cancers. And they also include primary thyroid lymphoma and very, very rarely metastatic carcinomas, which most commonly have been described as breast and renal mets. And the other thing to keep in mind when you have a patient with a thyroid nodule is to just think of non-thyroidal lesions in the area that can be mistaken for a thyroid nodule. For example, the parathyroid glands can also be confused for thyroid nodules on physical exam. So some risk factors, the thyroid nodule formation section of risk factors is very questionable. A lot of these I got from Up to Date, and I looked into where some of this data came from. So for example, smoking, obesity, alcohol consumption, those are all risk factors for various malignancies and just metabolic derangements in our body in general. But I was really curious as to like where the factors associated with decreased risk, like oral contraceptives and statins, came from. And so I would take these with a grain of salt. Most of these, obesity, alcohol, insulin-like growth factor, and those associated with decreased risk, like oral contraceptives and statins, are all based on observational cross-sectional studies with sample sizes around like 1,500 to 2,000. And so there's very little evidence to suggest an association, but it's just been described in the literature. I think the risk factors that we all know are very clear and well described are those associated with thyroid cancer. Age is a very important one. Thyroid nodules that present in childhood are actually more likely to be associated with cancer. And then, of course, in adults over the age of 60, that risk of malignancy is higher. The rate of thyroid cancer is also generally higher in men than in women. Prior head and neck radiation, a very commonly described risk factor, is a risk factor for thyroid cancer. And interestingly, something that I learned is that radiation-associated thyroid cancers are not more aggressive than other forms. History of stem cell transplants increase the relative risk to 3. And if that stem cell transplant was before the age of 10, that relative risk bumps up to 24.6. Size is very common. It's a very common marker to decide whether or not a nodule necessitates biopsy, and typically around 2 centimeters is that cutoff for an increased risk. A family history of primary thyroid cancers, and of course, rapid growth. If someone has a nodule that's been stable for many years, the same size without change, that's less concerning compared to someone who's had a thyroid nodule that has rapidly progressed over the course of 6 months. So starting off with the evaluation of thyroid nodules, I wanted to use this as an opportunity to just review a little bit of the anatomy. and the important landmarks to identify. So starting at, someone's like chin and working your way down, the first thing that you'll feel is the thyroid cartilage. You'll feel then a soft little divot, that's your cricothyroid membrane, and just below that is another rigid structure, your cricoid cartilage. Just below that is where you would feel the thyroid, and you would start medially to try and see if you can palpate the isthmus, and then progress laterally to feel the lateral lobes. Interesting, your finger pads are more sensitive than your fingertips, so it's always best to try and do this with your finger pads to perform the most accurate exam, although sometimes it's really hard to palpate thyroids in some patients. An important part of the exam, which I'm sure everybody knows, is to assess for asymmetry by having patients swallow, and that asymmetry typically suggests nodularity. Other important things to do are to make sure you perform a really good cervical lymph node exam, ask about compressive symptoms, dysphagia, dyspnea, hoarseness in their voice. Those are all suggestive of more concerning pathology. And something that I've learned to be mindful of, and I think part of this is just because of the clinic that I'm work in, the International Medicine Clinic, is just being mindful of the language and our approach to how we perform a neck exam, thyroid exam. We don't really think of our necks as a very vulnerable area, but if you have a patient that may be a survivor of domestic violence or someone who's lived in trauma concentration camps and has had very traumatic experiences, just being mindful of what that could elicit, and just using really appropriate language and thoroughly describing the exam as you perform it. So going on with the evaluation of thyroid nodules, you'll see the beautiful flow chart from Up to Date. I'm going to focus on the highlighted red parts first and kind of work through it. Typically, if you find a thyroid nodule clinically or it's incidentally found on an alternate form of imaging, the recommendation is to initially check a TSH and thyroid ultrasound. You'll see that if the TSH is suboptimal or low, below the lower limits of normal, there is a part of this pathway that actually does not utilize a thyroid ultrasound in the workup and diagnosis. And so typically the recommendation is to get a thyroid ultrasound initially with your TSH, but every patient is different, and taking into account how traumatic that experience might be, or just the cost or delay in care, whatever it may be, you can kind of make that decision on your own. But the TSH should definitely be obtained first. And if the TSH is normal or elevated, that's when you're going to use your ultrasound, your thyroid ultrasound, to determine whether or not those nodules or nodule meet criteria for an FNA biopsy. Typically, as a rule of thumb, nodules that are less than a centimeter are not biopsied unless they're associated with symptoms for your patient. So what are the ultrasound features associated with a higher cancer risk? The most commonly described findings that are associated with a higher cancer risk are hypoechogenicity, which is different than an anechoic cyst, and I'll show some examples. A solid composition, microcalcifications. The shape is very important. If it's taller than it is wide, that is more concerning. And of course, suspicious lymphadenopathy. Other things to think about is whether or not there's any extension beyond the thyroid tissue itself. Vascular invasion is another important component. And so there's a couple of ways to classify your thyroid nodules. There's one by the American College of Radiology, which we typically see a TI-RADS score on our thyroid ultrasound radiology report. And then there's another classification system by the American Thyroid Association, and I'll go through both. But before I do, here are just some example of what different thyroid nodules can look like. And so here in panel A, you have this like very beautiful regular border, solid hypoechogenic nodule. It is as wide as it is tall, very reassuring findings. And then here, this is an example of something that's anechoic. And so this is probably a fluid-filled cyst. Maybe it's a resorbing thyroid nodule that wasn't malignant and is now on its way out, or just a cyst that's developed on its own. Here's another one that has a pretty regular border, but interestingly here, now you see these linear rim calcifications, which are part of the one of the classifications point systems to determine how suspicious a lesion is. This one is a really great example of what an irregular jagged border looks like on a thyroid nodule. And if you could reimagine this image flip the other way, this would have been an example of a nodule that is taller than it is wide, but in reality, this one's wider than it is tall. So that is a reassuring finding despite the irregular border. Here, these small little punctate white spots are microcalcifications. And this one, you can see that there is a solid component, but there's also non-solid kind of anechoic spaces here. This one here has less of a defined border. It's almost difficult to make it out here on this side. It has these calcifications, but they have this acoustic shadowing where it looks like they're kind of just this long line leading up to the calcification. And that's what they call comet tails, which is another finding that radiologists look for on the thyroid ultrasounds. So the American College of Radiology calculates this TIRAD score. They look at the composition, the echogenicity, the shape, the margins, and then the foci, such as microcalcifications, rim calcifications. And they attribute all these points to determine the classification from TR1 to TR5. And then typically what you want to be mindful of is TR3 or greater. What's going to be important is determining the size of your nodule. A 3, mildly suspicious lesion, the cutoff is 2.5 centimeters. A 4, moderately suspicious, the cutoff is 1.5. And as you increase to a TR5, a nodule as small as 1 centimeter necessitates a fine needle aspiration biopsy. When you look at the American Thyroid Association, these are criteria sonographic pattern recommendations that were released in 2015, and they break it up a little bit different. They do benign, very low suspicion, intermediate, and high, and they describe the ultrasound features. And so this is a little bit more difficult to use because you don't have an exact point system. And so I think most of what I read online and up to date, the recommendation is to use the ACR. And I think part of that is also because if you look at the low suspicion lesions classified by ATA, the recommendation for an FNA is 1.5, whereas if you look at low suspicion or mildly suspicious on the ACR TIRADs, the cutoff is 2.5 centimeters. And so it is a little bit more strict. And so the thought is that the ACR TIRAD score results in a more accurate diagnosis and less unnecessary FNA biopsies. However, if you have a patient who has some symptoms that are uncomfortable, or they're very worried about this thyroid nodule, or maybe they have a personal family history, or have had some head and neck radiation in the past during childhood, you might want to then use the less aggressive cutoffs made by the ATA. So it's just kind of a shared decision-making process and personal preference. The ATA also has this wonderful table that shows you the different sonographic features that are described in the previous table and what they would look like on an ultrasound, and in increasing order of malignancy from bottom to top. And so this is kind of fun to look at. I think when I did a thyroid elective, they had this like all over the wall everywhere, an endocrine elective, sorry. So now you determine your patient has a TR3 to TR5 score on their thyroid ultrasound, and it meets the size cutoff for an FNA. You get an FNA, you get back a cytology report. Now, what do you do with that? So the system that's used with FNA biopsies is something called the Bethesda system, and it breaks it up into 6 classes based on the findings on the FNA cytology. Great place to think about this is to cut it in half. Classes 1, 2, 3 do not require any surgical approach, at least initially. They require either repeat ultrasounds or a repeat FNA, whereas classes 4 through 6, now you have to think about either a lobectomy or total thyroidectomy. You can get non-diagnostic FNAs. Those are classified as class 1.
Hey, Jessica, I think we've lost you there. Uh-oh.
The way I like to think about these classes is just split the list in half. Classes 1, 2, 3 typically just require a little bit more surveillance with ultrasounds or repeat FNAs. Classes 4 through 6, you're now thinking about surgically removing at least the nodule or lobe of the thyroid in which the nodule is located, or the total thyroid, depending on the characteristics. I think one thing I was talking about that I may have gotten cut off on is if you have a non-diagnostic FNA, the recommendation is to repeat it. And if you have 2 non-diagnostic, to just have a surgical approach. going forward. Benign lesions typically just require surveillance with repeat ultrasounds anywhere from 6 to 24 months. And then if you have atypia or follicular lesions of undetermined significance, you repeat the FNA in 3 months and just basically go based off this classing system again. One thing I actually now am thinking of is whether or not if you get class 3 again, what do you do? I imagine getting repeat FNAs every 3 months is probably not ideal. And then classes 4 through 6 is really just going to depend on how suspicious the findings on your cytology are for malignancy, and that'll dictate whether you do a lobectomy or total thyroidectomy. Other considerations there are whether or not the nodule is unilateral, whether it's extending to the contralateral side, whether there's extrathyroidal involvement, etc. So coming back to this, you have a thyroid nodule, but now the TSH is not normal, nor is it elevated, but it's actually low. The important next step here is not necessarily the thyroid ultrasound. You might need the thyroid ultrasound, which is why it's recommended to get it early on. But the next step here is to get a radionuclide thyroid scan and measure your free T4 and total T3. And this list further then separates depending on the functionality of that nodule on your radionuclide thyroid scan. We know that non-functional nodules, also known as cold nodules, are more concerning for malignancy. And that's why you look at the ultrasound features to determine whether or not that nodule needs to be biopsied versus a nodule that is functioning. You're now worried about maybe this is a nodule that is hyperthyroid and this patient has overt hyperthyroidism, or maybe they have a subclinical hyperthyroidism, and you either treat and observe in those cases. Another important thing that I forgot to mention early on is anytime there's a thyroid nodule, just go through your checklist of, with your review of systems of hyper and hypothyroid symptoms with your patients. It'll help if you ever get to this point as well. So what does a radionuclide thyroid scan look like? So this is when you inject like a radioactive iodine. The iodine is taken up by thyroid follicular cells so that they can make more thyroid hormone. They have a very high affinity for it. And so this is an example here of what a cold nodule looks like. You can see the entire outline of your thyroid gland. It has the radionuclide uptake, but now your nodule has very less uptake to no uptake compared to the rest of your gland. And then here's an example of a hot nodule. You still see the contours of your thyroid gland, but now you have a location where there's a lot more uptake. Other things you can see bilateral symmetrical uptake. A lot of times you see this in like diffuse thyroiditis or in Graves' disease. Your entire thyroid gland is very, very active. You might see both. You might see both hot nodules and cold nodules in your thyroid. And typically, you'll see that with toxic multinodular goiters. Another example of a hot nodule. Something that's really interesting is you can have an autonomous nodule. This is the only radionuclide scan here where you don't see the entire contour of your thyroid gland. You just see this thyroid nodule. And so this thyroid nodule in some shape, way, or form is suppressing the remainder of the gland. And then in thyroiditis, you'll just see very little uptake diffusely throughout. And so talking about the evaluation and workup, I wanted to spend some time talking about different thyroid findings that we typically see in internal medicine in our continuity clinics and sometimes even inpatient with our patients. And so starting off with the most classic finding is goiters. Goiters are very commonly due to iodine deficiency worldwide. That's the most common cause. When you goiters are very, very obvious. They're not a nodule that you palpate. You kind of see this bullfrog-like neck appearance. Things you want to ask patients with goiters are if the rate of change in size has been rapid or if it's been pretty stable over many years, if there's any thyroid risk, thyroid cancer risk factors that they may have, and you want to ask about symptoms of hyper and hypothyroidism and also ask about compressive symptoms. Many times, goiters, you don't do much about them unless they're disfiguring to the patient and they're very worried, or if they have compressive symptoms, then that would require surgical removal. And then other things you want to look out for is venous obstruction. If a goiter is large enough, it can actually compress your SVC. And so you'll ask them to raise their hands up and they'll have a positive Pemberton sign, which is when they have facial plethora. Also in the bucket of goiters are multinodular goiters. The most common cause of these is just general. This is the most common cause of thyroid enlargement in older adults. The frequency of malignancy in multinodular goiters is the same as in patients who just have a solitary thyroid nodule. If you're worried about substernal goiters, you might want to consider a CT or MRI, just because substernal goiters have a higher tendency to obstruct the airway. And so on a CT or MRI, you might actually look at the tracheal lumen. And if it's less than 1 centimeter, that's pretty concerning. I was reading through some of this, and there were some recommendations on if the tracheal lumen is very narrow to obtain spirometry. I don't know how useful that is in clinical practice. I imagine that if you have airway compression from a substernal goiter, you would probably refer to surgery or ENT for removal. But I thought it was a good learning point to remind ourselves of what that would look like on a flow volume loop, and tracheal stenosis, both from damage to the trachea or external compression, has a very fixed obstructive appearance where you kind of have a flat limb both on the inspiratory and expiratory loop. So I included it for just a little refresher on this fun finding. And then other things to just think about: if patients are having hoarseness and voice changes, sometimes they can develop vocal cord paralysis from the substernal goiter, and multinodular goiters. Another important learning point that I learned was to avoid iodinated contrast, because that can precipitate an iodine-induced hyperthyroidism. And then lastly, diffuse goiters. You typically see diffuse goiters in autoimmune thyroid disease like Hashimoto's, Graves' disease, can sometimes be seen in the IgG4 related diseases as well. These are more commonly associated with a genetic predisposition, smoking, and iodine deficiency. And typically ultrasounds are not recommended unless there is asymmetry within the diffuse goiter. And then in that case, you'd probably be worried about additional nodules in there that may be separate from the autoimmune diffuse goiter that's present on exam. And just a little pitch for all the different symptoms of Graves and hypothyroidism to always remember to ask. So thyroid cancer, just wanted to talk a little bit about this as well, just because thyroid nodules, about 5% of them are due to thyroid malignancies. Thyroid cancers have a pretty great survival rate. The 5-year survival rate is about 98%. They're very easy to treat. The most common types, papillary and follicular, which make up 95% of them, are actually pretty well differentiated, tend to be less aggressive compared to anaplastic, which makes up 1% and is very aggressive, and sometimes doesn't really have any great treatment options. So interestingly, the papillary thyroid carcinomas very commonly will spread to cervical lymph nodes, whereas follicular thyroid carcinomas will not. But follicular can metastasize to bone and lung, whereas the papillary have a very low risk of distant metastasis. The mainstay of treatment for thyroid cancers is truly just surgery. If it's unilateral, small, well differentiated, you'll go for hemithyroidectomy. If there's expansion beyond the thyroid, vascular invasion, lymph node involvement, or distant metastasis, you would consider a total thyroidectomy. Important to counsel our patients on the surgical risks associated with lobectomy or hemithyroidectomy and thyroidectomy are hypocalcemia, because you can get damage to your parathyroid glands, and then voice changes from injury to the recurrent laryngeal nerve. Although papillary and follicular carcinomas are the most common, I wanted to talk a little bit about anaplastic and medullary. They are significantly less common, about 1% to 2%, but they have some interesting learning pearls that I thought I'd mention. The anaplastic thyroid cancer, as I mentioned before, is very rare, very aggressive. Typically, it presents as a rapidly enlarging neck mass, so have a higher suspicion when you see this. Many times they're unresectable just because they've expanded beyond the thyroid tissue itself, can cause compressive symptoms very rapidly. The median survival in these patients is about 5 months, and many times the treatment that's recommended is palliative measures. And then medullary thyroid cancer, just super interesting from like an endocrine standpoint. It arises from the parafollicular cells, which produce calcitonin. There's some controversy on whether calcitonin should even be measured initially when there's a thyroid nodule. It doesn't seem like it's recommended, but I do wonder if it's a great surveillance marker for medullary thyroid cancers. As you know, the medullary thyroid cancers are associated with RET oncogene mutations, and so getting a really good family history, considering genetic testing, and making sure that you screen for pheochromocytoma before pursuing any surgical approach to your thyroid carcinoma in this case is very, very important. And I've included this really cute looking figure from, I think, Osmosis on the different P's associated with MEN2A and 2B. So if you have a patient who has thyroid cancer, they get a hemithyroidectomy or a total thyroidectomy, when do you consider post-operative iodine ablation? Typically, post-operative iodine ablation is recommended for cancers with intermediate to high risk of recurrence. And so those are that have already spread to the lymph node, those that have extrathyroidal extension, and those that have had vascular invasion, and as well as anyone who's had a thyroid cancer that's metastasized to other parts of the body. Radioactive iodine can be very helpful in killing that remaining and residual thyroid tissue. And so the way radioactive iodine works is these patients will typically drink this radioactive iodine solution or ingest a capsule. That'll go through their GI tract and be absorbed into the bloodstream. And then because thyroid follicular tissue is very basically takes up iodine very, very well so that it can produce more thyroid hormone, it gets absorbed into any remaining thyroid tissue that they may have. And then you use radiation therapy to kill all of that thyroid follicular tissue. Another important area of thyroid cancer management is TSH suppression. TSH suppression is also used for intermediate and high risk differentiated thyroid cancers. So the same risk factors I mentioned before. And the theory behind this is that thyroid follicular cells are very highly responsive to TSH. They're stimulated by TSH. They produce more thyroid hormone. And so in some patients, it's beneficial to administer levothyroxine lifelong to suppress any TSH to prevent any further stimulation of thyroid tissue that they may have remaining. Depending on how high the risk for recurrence is in the initial thyroid cancer is going to determine what your TSH levels are. So these patients require frequent routine TSH checks. If they had a very low risk malignancy, the lower limit of a normal TSH up to 2 is appropriate. But if they had a very high risk thyroid cancer or high risk of recurrence, meaning they've had lymph node involvement or METs, you want a lower TSH goal of less than 0.1. And so if you have a patient who's had thyroid cancer and has had surgical removal, then the next steps are really to think about how are you going to monitor them for recurrence or what's going to be your surveillance approach. And typically this is done with serum thyroglobulin or thyroglobulin antibody. You're going to use serum thyroglobulin overall if it's persistently elevated or present that is concerning for recurrence or persistence of the disease. The only time you would actually use thyroglobulin antibody is if it's present. The presence of thyroglobulin antibody actually makes interpretation of thyroglobulin levels difficult. And so you would use your antibody titers as your surrogate marker. And just as you would expect, lower titers over time suggest a favorable prognosis. Another important thing to remember in your continuity clinics is patients typically require a repeat ultrasound around 6 to 12 months after their thyroidectomy. And other things you might want to think about if you're worried about recurrence or it's suspected, but you can't identify anything on an ultrasound is just consider CT MRI imaging or radioactive iodine scanning. And so this over here on the left is a good example. Typically with a normal radioactive whole body scan, you'll see this like increased uptake in the oropharynx. You'll see it all throughout the GI tract, and the radioactive iodine is excreted in the urine. So you'll see it in the bladder. If you see it anywhere else like here, which I'm not really sure what this is, this might be the hip, which may or may not make sense, but nonetheless, this is abnormal. So that's another option you can take if you're worried about recurrence. That was all pretty fast, but does anyone have any questions?
Awesome, Jessica. Thanks so much. There were a couple of things in the chat. Jordan asked, has anyone ordered a radionuclide thyroid scan in our system? If so, how long does it take to get scheduled / done? I don't think I have. I feel like I may have once. I can't.
I personally have not either. That's a great
Yeah,
question.
I've seen him in endocrine clinic, of course. That's a good question, Jordan. I don't know. I don't know if anybody else does. Um, there was also some discussion earlier about the taller than wide thing. And I think Lindsay found this great article. It sounds like, I guess I don't know if you came across anything in your reading, but I guess our interpretation, and this was, I think, when you got briefly disconnected, was that that has to do with like the ultrasound probe not compressing the nodule as much as when it is wider than tall, and the lack of compression is more associated with malignancy. I don't know if that's, did you come across anything else in your reading as to why the taller than wide sign is a thing?
Yeah, I did see that because that's more suggestive of having more solid composition to your nodule versus having something that's like cystic fluid filled. And also, I think with the calcifications, that tends to stiffen up the composition of your thyroid nodules. But I also saw that a lot of this is orientation based, and I think I can't remember now. But yeah, that I did see that.
Okay.
Jessica, I actually have a question that came up during, we were actually talking about a case of papillary thyroid cancer yesterday in Chief of Medicine. And one of the questions that came up was about like around sort of prognosis, which tends to be typically pretty good. But in terms of like, I'm not sure if you found anything in your reading about sort of like typical rates of growth for like papillary thyroid cancer. I don't know. It was just something that came up of like, are there any issues with sort of if there's delay in diagnosis with something like a papillary thyroid cancer?
That's a great question, Lindsay. I actually didn't look into the rate of growth of the individual and whether or not some forms are more delayed in their diagnosis, but I'm happy to look into that later and see if I can find anything.
Awesome. The only other things I'm seeing in the chat, Luke says he's seen the radionuclide scans and the VA. Awesome. And Lindsay shared that article, which has, yeah, this adorable child's drawing of lions for that article on the taller than wide sign. Great. Well, we can go ahead then. If there's no further questions, we can go ahead and take a little, we can go ahead and take our break. I think as far as timing, we'll, I guess, let's see, Sophie.